So I'll be talking on whole genome sequencing, my experience with the utility of the pillars of microbiological diagnosis. If you want to diagnose mycobacterial infection or TB, you have to first detect TB, and we have plenty of methods to detect TB. Then you have identification, DST, and then you do a cluster analysis. Now, cluster analysis is something that has come into vogue because of whole genome sequencing. So there are many methods for detection and identification. DST, you have phenotypic DST, which takes about 4 weeks, 3 to 4 weeks for liquid culture. So it's a long duration. So if you look at whole genome sequencing, it manages to do identification, DST, and cluster analysis in a single assay. It takes 14 days if you give them a culture or a sample. It depends on the lab whether they process a sample or the culture isolate. So whole genome sequencing is like a Swiss Army knife, which can be used very well in diagnosing and treating, identification and treating, and also identifying outbreaks in case of tuberculosis. So we'll be discussing as we proceed. So this is the algorithm for diagnosis of TB. You usually have a clinical diagnosis in case of the clinician who thinks the patient is suspected to have TB. You do a smear AFB, culture AFB, or a CBNAT. CBNAT is widely available. We all use CBNAT very frequently, and if it comes positive, we go for a drug susceptibility. It could be partial drug susceptibility using a line probe assay, or a drug susceptibility using the phenotypic assay, which could be first line, then reflex second line if the first line comes resistant. So it's a long duration, long way to go before we come to know the susceptibility for all 18 drugs that's available for treating TB. So there, the whole genome sequencing comes into picture. Now, whole genome sequencing, there are two different types: actual whole genome sequencing, where the whole genome of the bacteria is sequenced and analyzed. So it's a huge amount of data that is, each mycobacteria is 4.4 billion base pairs, and 4,000 genes are there, and you have the data produced would be something around 3 to 4 GB of data. So make sense of that 3 to 4 GB of data. Base pair data is very difficult, and it's a very tedious procedure. You need good bioinformatics person and a good molecular biologist to get such robust data. And then comes the targeted NGS. Targeted NGS is a cheaper and shorter version of whole genome sequencing, where you don't amplify the whole gene, the 4.4 million base pairs. You amplify only 10,000 base pairs, or you amplify only 50 to 100 genes. You don't amplify the 4,000 genes. You may not require 4,000 genes. So we target a few particular genes that are responsible for resistance or identification, amplify it, and then do a whole genome sequencing using an NGS, and then come to a conclusion. So it's a shorter version, and it's cheaper alternative, and it can be done directly on samples very effective. So that's targeted NGS and whole genome sequencing in brief. So this is a snapshot of what happens in the whole genome sequencing. I won't go too much into details. I'll just tell you that what happens. It depends on the lab. If the lab says that I can process a sample for whole genome sequencing, you can just sample. If the lab says that it works only on isolates, you can send mycobacterial isolates. They extract the DNA, cut the DNA into small pieces. They may prepare library, and ultimately they feed into the whole next generation sequencer. A database is produced. The data is the whole sequence is analyzed. If it's a whole genome sequencing, the data is 3 GB, a huge amount of data. The bioinformatic person will align it, make sense of it, and then use these databases that are publicly available. MTB-Seq, ReSeq, TB, and Cryptic. These are different databases that are available online, where they feed the data and analyze and try to make sense of what's happening with the mycobacteria. They try to identify the SNPs, that's a single nucleotide polymorphism, that is a change in the sequence of the base pairs. Change in the sequence of base pairs is identified. These change in the sequence of base pairs will ultimately lead to tell you which gene is involved and the mutation that it confers. The mutation will also identify the amino acid chain that happens. So if all these things are identified by using this database, and once the mutation is identified, it also tells you whether it's clinically relevant, whether it confers phenotypic susceptibility also. So that way you get a susceptibility for different drugs based on the different genes where the SNP is identified. And then another advantage is that by knowing the whole sequence of the bacteria, you can also identify the strain. If it is Mycobacterium tuberculosis, you can identify the lineages, lineage 1, 2, 3, or 4. And if it's not Mycobacterium tuberculosis, you can identify non-tuberculous mycobacteria. You can identify the different members of the Mycobacterium tuberculosis complex, like the Mycobacterium bovis, microti, africanum. It's very rare to find bovis, microti, or africanum in any setup. Most often you will get a report saying that it's lineage 1, 2, or 3 of Mycobacterium tuberculosis complex. All these are compiled together to produce a report with all these details included. So that is how whole genome sequencing of Mycobacterium tuberculosis occurs in short. So it depends on the lab. but the lab would like to is comfortable in sequencing the sample or sequencing the Mycobacterium isolates. So whole genome sequencing, if they are doing whole genome sequencing, all 18 known drugs, the resistance can be determined. So all the genes are analyzed, 4,000 different genes are analyzed, including the genes encoding for these all 18 drugs. So all 18 drugs can be determined. Resistance to all 18 drugs can be determined. If you're doing a targeted NGS, somewhere around 10 to 12 drugs only could be determined, because it's a multiplex PCR where they include only specific genes that are relevant. So you may not achieve the whole 18 drug panel. You will achieve only 10 to 12 antibiotics at the most in case of targeted whole genome sequencing, targeted NGS. And once the SNP is identified, the mutation is identified, then comes the job of identifying the confidence level for the mutation to be associated with the resistance, phenotypic resistance. So there will be a lot of SNPs that are identified, a lot of mutations, but some mutations are benign, do not confer resistance. So if there's a high association, high confidence, that means a strong association is there. It is known to cause phenotypic resistance. It is reported as resistance. Moderate means moderate association is there. More data is required. You have to identify. You cannot report it as resistant, but you can report it that there is a mutation that has been identified, which is of moderate significance. It may not be associated with phenotypic resistance. Minimal is something that is totally benign. It doesn't confer any phenotypic resistance. So you get a lot of mutations, SNPs, but it did not confer phenotypic resistance based on the association, high, moderate, or minimal association. So let's look at a particular report of 3 strains, strain 1, strain 2, strain 3, and strain 4, where we send these isolates and it underwent a whole genome sequencing. The first thing you identify is the lineage of 4, 3, 1, and this particular strain was not Mycobacterium tuberculosis, it was Mycobacterium bovis. And these 3 were Mycobacterium tuberculosis, so lineage 1, 3, and 4 were identified. When you look at RPOB mutation, that is confers resistance to Rifampicin, strain 1, 2, and 3 had the mutation which conferred high level of resistance to Rifampicin, so they were reported as resistant. But Mycobacterium bovis had an SNP, a mutation that didn't confer resistance to Rifampicin, though it was reported as Rifampicin susceptible. So this is a benign mutation, so it will not be reported as resistant. Similarly, in case of pyrazinamide, PNCA mutation, strain 1, 2, and 4, the mutations were significant, conferred resistance, so they were reported as resistant. In case of strain 3, the mutation that was identified did not confer phenotypic resistance, a benign mutation, so it was reported susceptible. So in a whole genome sequencing report, you may find mutations which may have minimal or moderate association, so it may not be reported as resistant, it will be reported as sensitive. So after knowing the resistant phenotype of the bacteria, you can also identify whether they are clustering or not. So you have the whole data of the bacteria, the lineages and all the SNPs. So depending on the number of SNPs, if the SNPs in a two strains are less than 10, something around 5 to 12 SNPs, then they are almost identical. Those bacteria are almost identical. It could be either recent transmission or it could be a contamination. It could be an outbreak, a clustering, or it could be a contamination also. If the lab is sending similar isolates through whole genome sequencing, you can question the lab saying that you are having identical isolates being sent for different patients. Please check whether it's contamination or not. So you can identify outbreaks by looking at the whole genome sequencing data. But this is not possible if you do a targeted NGS. Targeted NGS will not have that much amount of data to come to a conclusion whether there is an outbreak or not. So WGS also helps us to identify relapse and reinfection. Relapse is recurrence of the same original infection. So if the SNPs are less than 10, 2 different strains have been identified. From a previous infection, you have a whole genome sequencing data, and a recent infection, you have a whole genome sequencing data. You compare both of them. Both the isolates have the SNPs, number of SNPs is less than 10. It is a relapse. Reinfection is you have an infection with a totally different strain. That is, you have the whole genome sequencing data of the first isolate, the second isolate also you have, and the difference in SNPs is more than 100. It means that it is a reinfection, a new strain that is causing infection. TB relapse rate is very high in India, 10%. So it makes sense to identify whether it's a relapse or reinfection in Indian setup. It also identifies mixed infections. Mixed infections could be either an infection with MTB or NTM, or it could be between 2 different strains of mycobacteria having 2 different phenotypic resistance mechanisms. One is sensitive, one is resistant. So having a mixture of mycobacteria also complicates the treatment and the outcome of the patient, because these may not respond to the normal antitubercular therapy. If you're targeting the sensitive pathogen, because the sensitive pathogen is more likely to grow in the culture, and you're more likely to do a DST for the sensitive pathogen because of the fitness cost associated with developing resistance. So more likely you are going to miss it in phenotypic susceptibility, and it may lead to poor outcomes. So it's better the whole genome sequencing comes into the picture, saying with more data saying that it is a mixed infection with two different strains having different susceptibilities. So better to treat the resistant infection also. So published data from Western literature shows that the sensitivity and specificity of WGS when compared to the gold standard DST is very, very good. 97%, 99% for isoniazid, rifampicin, ethambutol. Everything is more than 90%. But if you look at the Indian data, the sensitivity is somewhere around 70 to 80%, specificity also from 70 to 80%, because the gold standard DST may not be as great as what is used in the Western countries. So your DST should be very, very perfect. We all know that pyrazimide susceptibility has got a lot of false positivity because the pH level has to be maintained. So you should be having a very, very good lab to do a DST to compare it with whole genome sequencing. If your gold standard DST is inferior, then your susceptibility and sensitivity will suffer. So it has got excellent sensitivity and specificity, provided you compare with the gold standard DST, which is done very properly. Ethinomide has got poor specificity because usually the whole genome sequencing picks up INHA mutation to look for ethinomide susceptibility resistance. But there are many other genes that are responsible for ethinomide resistance that may not be looked into. They don't have data about it, whether it confers phenotypic resistance. So data is lacking. So as a result, ethinomide has got a poor specificity and sensitivity. So this is an article where they compared 20 MDR and 5 XDR-TBs. They were all resistant by Xpert, gene Xpert, rifampicin resistant. So they did line probe assay, they did phenotypic DST, they did an Xpert, and they compared everything, and they did the whole genome sequencing and compared the agreement between each other. When they compared the culture DST with the Xpert is rifampicin resistant, when they considered rifampicin only resistant, then the association agreement was only 49%. But if you by default consider all rifampicin resistant isolates as resistant to INH also, the agreement increased to 68%. That's what we do in India. Any rifampicin resistant isolate in gene Xpert is by default considered MDR unless and until proved otherwise. So we'll have a agreement of only 68% in that case. When culture DST was compared with line probe assay, the agreement was only 63%. But when culture DST was compared with whole genome sequencing, the agreement was 93%. So whole genome sequencing gives you the best agreement when with DST. So whole genome sequencing should be the way forward for doing genotypic DST rather than doing a phenotypic DST in case of Mycobacterial. Now, whole genome sequencing has been endorsed by FIND and WHO. They have a technical guide. It's freely available online. You can look into it. So they also endorse whole genome sequencing for genotypic drug susceptibility rather than going for a phenotypic susceptibility, which takes long, especially for first-line antibiotics.